Hello, everyone. Um, Thank you for attending this presentation. Dr. Aviso or Kay will just play the pre-recorded presentation because of my intermittent connection, but I will be here during the entire presentation and the Q&A. And I would also like to thank PAASE for this opportunity too. And I think without further ado, we can start.
Okay, thank you.
Dr. Aviso,
All right, let me just
thank
get
you.
the.
Hello, everyone. Thank you for attending my presentation. Thank you also to Dr. Aviso for facilitating this presentation and for PAASE, the Philippine American Academy of Science and Engineering, for this opportunity to share the findings of our paper entitled How Effective is Community Quarantine in the Philippines? A Quasi-Experimental Analysis. This paper is co-authored by Glazer Nino Vasquez, who is also a PhD student in UP. Okay, COVID-19 at a glance. The first 2 decades of the 21st century have been eventful, to say the least. There have been two influenza pandemics, the 2009 H1N1 and the 2020 COVID-19, resulting in a health crisis, which in part was triggered by the novelty of the experience and was worsened by governance challenges. COVID-19, which was declared by the World Health Organization as a pandemic on March 11, 2020, is different from the 2009 H1N1 flu pandemic in that, epidemiologically speaking, it is the first flu pandemic caused by a coronavirus or SARS-CoV-2. In the Philippines, the first case of COVID-19 was reported officially on January 30, 2020. On the first week of February, two more cases were reported. On the 1st of February, first mortality was recorded, and sadly, it was the first recorded outside China. On March 6, 2020, the fourth and fifth cases were confirmed, and it was the beginning of a sharp increase in incidence and mortality. And then finally, on March 7, community transmission was officially confirmed. Okay, per the previous slide, since the community transmission on March 7, 2020, we can see a dramatic increase in the number of cases and deaths. And as of latest statistics in the ASEAN region, the Philippines is one of the top 3 countries with the most number of COVID-19 cases and deaths. The latest statistics found in the website of the Department of Health or DOH shows that as of March 2, the Philippines already has about 580,000 confirmed COVID-19 cases and about 12,000 deaths. One of the government responses in stemming COVID-19 transmission was to impose different types of community quarantine in different parts of the country at different time periods. Our paper basically aims to examine whether these CQs or policy interventions were able to control the spread of the virus after accounting for health capacity and social demographic characteristics. Basically, we also ask whether CQs were able to flatten the epi curve or reduce COVID-19 incidence and mortality using quasi-experimental analysis. In particular, we want to examine the policy relevance of lockdowns by integrating into epidemiology and analysis of a public health policy the economic and econometric tools. During a pandemic, NPIs such as PPE, hand hygiene, school closures, and prohibition limitation of mass gatherings were implemented. Although there have been previous studies on the effectiveness of NPIs in stemming the chains of transmission during the last flu pandemic in 2009, there is still a lot to be learned regarding their timing and optimal implementation, especially in the face of the current COVID-19 flu pandemic. But everybody recognizes that they actually help distribute the number of COVID-19 cases over a longer period and reduce peak capacity needs. There is also paucity in research on NPIs implemented in different countries during COVID-19, which is understandable given that this pandemic is quite recent and that more observations need to be gathered to conduct an evidence-based analysis. We also believe that our findings could help governments in choosing and implementing the right policy interventions. Some contributions of our paper. First, to the best of our knowledge, this is the first paper to examine the impact of a CQ or a lockdown as a health policy while controlling for other confounding factors during the COVID-19 pandemic in the Philippine context. We basically conducted a natural experimental analysis and used a novel data that we constructed. This is the country's first longitudinal data on quarantine, COVID-19 health outcomes, health capacity, and sociodemographic characteristics. And basically, we took advantage of the spatial and temporal variation in data. The Philippines is an interesting country to analyze since there have been dozens of CQs imposed on different cities and provinces at different periods. For example, Metro Manila has been under 4 CQs during our study. First, GCQ on March 15, then ECQ from March 17 to May 15, then MECQ, modified ECQ from May 16 to May 31, and finally GCQ from June 1 to June 15. We want to examine whether the many CQs imposed were helpful in combating COVID-19 or whether they led to public confusion and a worsening of health outcomes. Okay, so discussing the review of related literature, social distancing in the literature. Although there is a dearth of evidence-based studies on NPIs, the findings and experts' opinion thus far suggest of their efficacy in curtailing the disease spread. Social distancing, whether voluntary or otherwise, for example, school closures, bans on public gatherings, and cordon sanitaire, to cite a few, when combined with other NPIs such as personal hygiene techniques and patient and provider use of masks and other PPE, and sufficient health capacity become an effective tool in stemming the spread of the virus. For example, during the 2009 H1N1 flu pandemic, the younger people were more affected, and therefore school closures in Canada and the US became an important intervention in stemming the human-to-human transmission of the virus. In Canada, School closures reduced the transmission by more than 50% among the school-aged children. We also found a study by Ahmed and others, and they found that non-healthcare workplace social distancing measures actually decreased and delayed the peak influenza attack rate. And the decrease was actually more pronounced when the social distancing measures were actually combined with other NPIs or PIs, but they are less effective with lower compliance. Although the NPIs are low cost, health technologies that can improve the health outcomes and even save lives, they are not without weaknesses. Aside from the costs associated with endorsing and implementing them, some NPIs have direct economic, social, and political costs. For example, the mandatory use of PPE, cordon sanitaire, and school and mass transit closures can lead to business shutdowns, PPE price inflation, and unemployment. And in some cases, the costs of the proposed public health interventions may be higher than the costs of the disease. Aside from the costs associated with the use of NPIs such as social distancing, the efficacy of social distancing measures actually rely heavily on behavioral adaptation. For example, the response and decision of the public to comply and follow the protocols and guidelines about the implementation and use of these NPIs. For example, the full benefits of social distancing are not realized when an economic agent is selfish and is only concerned with his own utility and own risk of infection, and disregards the fact that his or her response and decision affect the outcome, affect the common good or public health. Also, the role of incentives cannot be ignored. And generally, economic models have shown that individuals, when left on their own, tend to underinvest in prevention and control of a disease. For example, individuals tend to underinvest in vaccines, which is a classic externalities problem. And in such cases, public interventions are necessary. And in the case of vaccination, a simple yet costly subsidy can incentivize individuals. Fenichel in 2013, in his paper, incorporated individuals' economic behavioral response into the SIR model, or susceptible, infected, recovered model, to show the effectiveness of a public health, such as social distancing, during an epidemic, which can be affected by behavioral incentives. He found that health policy interventions can enhance the welfare of the public. Public health can also be modeled as an impure public good, in which individuals have partial ownership of it, even if they have no regard for it, as in the case of vulnerable individuals who choose to voluntarily avoid infection for their own well-being. In effect, when an individual tries to avoid infection for his or her own welfare, other individuals also benefit, and this is due to positive externalities, and consequently, the risk of infection also decreases. Following the article of Fenichel in 2013, and using a simple health outcome function wherein health is a function of capital, labor, and other factors, we study how effective the epidemiological interventions or CQs imposed by the Philippine government in stemming COVID-19 incidence and mortality, given the country's health capacity and socio-demographic characteristics. Although individuals' incentives to comply are inherent in the types of quarantine imposed, there are cases when individuals are given more freedom to self-distance. And in such cases, we indirectly control for these incentives using urbanity and poverty incidence, because in the literature it was found that individuals with low income and those in rural areas basically engage less in self-protective behaviors such as wearing a face mask and correctly and social distancing. Social distancing in the Philippines during COVID-19. As already discussed in previous slides, the first CQ or lockdown was imposed in Metro Manila on March 15. And then on March 17, the entire island of Luzon was under ECQ until April 12, which was extended until April 30 and then re-extended to May 15 under EO 112. On May 15, IATF put various areas under different CQs until May 31. And then on May 29, IATF under Resolution 41 set the CQ guidelines for the entire country from June 1 to June 15. Okay, in this table, we are just basically showing that other types of CQs were imposed in other areas of the Philippines, such as Visayas and Mindanao. And this can be found in the appendix in our paper. These are the definitions that we followed, and basically these are the same definitions that were written in IATF Omnibus Guidelines, and we also sourced from other news and executive orders and resolutions. So we're basically using 5 types of CQs, okay, GCQ, CQ, ECQ, MECQ, and MGCQ. Okay, for the methodology, as I mentioned a while ago, we are using natural experiment on a novel panel data that we constructed. We basically compare the response of the treatment group, those provinces and districts in Metro Manila under CQ, to a certain treatment or intervention, which is CQ, with that of the control group under a different CQ or none at all. We also compare across time, that is before and after the quarantine was imposed. Basically, we estimate how the health outcomes in these two groups, treatment and control group, evolve before and after the pronouncement of a quarantine. And the most apt methodology is difference in differences, which is considered as a quasi-experiment. Okay, the base model that we are using in this paper is as follows. We first wanted to examine how ECQ affects health outcomes, which is Y sub HPT here. H is actually an index for health outcomes from 1 to 15. P is the index for provinces and districts. T is for time, index daily from January 30 to June 15, 2020. And then we used 15 health outcomes, as I've said. The first 8 health outcomes pertain to daily new cases and deaths, which could be, so this 8 actually were total male and its proportion to daily new cases, vulnerable cases, incidence rate, crude mortality, mortality rate. And then the second 7 health outcomes are basically daily cumulative version of the daily health outcomes. Okay, ECQ is a discrete variable equal to 1 if ECQ is imposed on province P at time t. First, we didn't control for other factors, and therefore the coefficient that we are concerned about is actually the DID estimate or the average treatment effect, which measures the effect of the policy on health outcomes. And this is the DID estimator, which is basically the difference over time in the average difference of COVID-19 mortality in the two treatment regimes, assuming that we're looking at COVID-19 mortality here. And our null hypothesis simply tests whether ECQ is effective or not. Our model actually extends beyond a 2x2 model or period 2 groups, and therefore we use the generalized DID given multiple time periods. And in practice, fixed effects regression model is used as an estimator in DID. Therefore, we use fixed effect regression and DID approach to control for unmeasured time invariant confounders also in determining the efficacy of ECQ. For example, a province may have social distancing measure already ingrained in its culture compared to another province. We also control for time effect, which is province invariant. For example, initial price inflation of required PPE in public spaces. Our second model is basically an extension of our first model, and here we control for health capacity and socio-demographic characteristics. So health capacity is divided into two. We have time variant and time invariant, and then we also have socio-demographic characteristics, which I will discuss in later slides. And then we also want to capture heterogeneity through the interaction of the time invariant health capacity and socio-demographic characteristics and ECQ. And our null hypothesis is as follows. So the partial derivative of health outcome with respect to ECQ, and this measures efficacy of ECQ. We are also concerned with heterogeneity and whether health system is effective. Our model 3 is basically changing ECQ to a discrete variable which is equal to 1 is if a province is under any CQ. Finally, we have a fourth model, which is a multi-treatment, multi-group, multi-period scenario. So here we used all 5 types of CQs, and each treatment group can serve as a control group to every other treatment group. Okay, and we use the ID FE also. And this is the model that we are gonna estimate. Okay, we're in quarantine is any of the 5 types of quarantine: ECQ, MECQ, GCQ, MGCQ, and CQ. And the rest of the variables are similar to those described in equations 1 and 3 to 5. We also recognize that in empirical literature, treatment effects can vary over time, and therefore we consider both the real-time or contemporaneous effect and the lagged or delayed effect of a CQ on health outcomes. So there are 2 sources of lagged effect. One is delay in DOH reporting and individual reporting. So we also, therefore leading us to also examine the impact of a CQ 1 to 3 weeks later. Okay, some data description. So as I've said, a panel data is more apt because it addresses both spatial and time variations, and also takes into consideration time invariant unobserved heterogeneity. We basically were able to construct or include 81 provinces in our dataset and 4 districts of Metro Manila. We used dataset from January 30 to June 15, and we were able to construct a dataset with an observation of 11,730, and basically merging 7 individual panel datasets. For example, health outcomes came from DOH, PPE from DOH, CQs from different official government pronouncements, and news outlet. We also used health capacity from DOH and social demographic characteristics from PSA. Okay, in this table, we're basically showing the summary statistics of the 15 health outcomes that we used. And I just want to highlight some numbers. Okay, the Eastern Manila District, or the second district, comprised of the cities of Quezon, Mandaluyong, Marikina, Pasig, and San Juan, recorded the highest number of confirmed daily cases among the vulnerable group, about 104, and total number of daily deaths at 21, last March 31 and April 29 respectively, while Cebu had the highest total daily cases 324, and male cases 175 last June 3. In terms of the policy variables, basically our data set shows that 64% of the observations were under lockdown, 27% were under ECQ. And then, like I've said, we use two types of health capacity, one time invariant and one time variant. And I just want to highlight in this table that it shows a skewed distribution of health workers and health capacity across the country. In particular, the second district of Metro Manila had the most number of doctors, about 7,000, and other health workers, about 11,000, which translates to about 15 doctors and 23 other health workers per 10,000 population, while the province of Siquijor had the least number of doctors, 8 only, and other health workers at 85. NCR, on the other hand, had the most number of beds at about 7,431, or 23 beds per 10,000 population. This satisfies the World Health Organization requirement of 20 beds per 10,000 population. An autonomous region of Muslim Mindanao, meanwhile, only had 183 hospital beds. Metro Manila again had the most number of health facilities for testing COVID-19 and the most number of individuals tested, which can be attributed to the high incidence in the region and a better health capacity. It also had the highest number of available PPE at different periods. Okay, here I want to highlight the social demographic characteristics that we use in the paper. So we use population, poverty, and urbanity. Basically, in the literature, we found that poverty is found to be positively correlated with the transmission of infectious diseases such as COVID-19. For example, lack or poor access to safe water and sanitation, as well as inadequate housing, may lead to an efficient spread of infection. And then, in terms of population and urbanity, population, particularly density and urbanity, appear to be associated with the spread of an infectious disease. For example, on the Diamond Princess cruise ship, both the basic reproduction number of COVID-19 virus and population density were about 4 times higher than that in the epicenter of Wuhan, China. And therefore, uh, we decided to include these variables as they can affect COVID-19 health outcomes. And we found that in our data set, 28% of the provinces are considered poor, okay, and that 65% is the maximum poverty incidence. Okay, next I want to discuss the basic results of the paper. First, I want to discuss the results of estimating just the base model, meaning the impact of ECQ on health outcomes without any control variables, and then extending this and adding other control variables, such as such as health capacity that varies over time, and then social demographic characteristics and health capacity that do not vary over time. And in both models, we use fixed effects. And basically in table 4 in the next slide, we find that ECQ initially is positively associated with the following daily COVID-19 health outcomes: daily cases, male cases, and vulnerable cases. However, once we add social demographic characteristics and health capacity, we find that ECQ becomes effective in lowering daily cases, male cases, and vulnerable cases. Or another way to put this is that ECQ as an intervention policy becomes effective in bringing down COVID-19 daily new cases when, when combined with sufficient health capacity and when preferences to comply are accounted for. In particular, the results of our post-estimation linear combination analysis tests of ECQ coefficients reveal that provinces under ECQ had 9% lower daily new cases, and to 9% to 12% decrease in daily new cases, and then 1% decrease in male cases, 10% decrease in male cases, and 6% decrease in vulnerable cases. To summarize, we found that using FEDID analysis, ECQ is not effective by itself. However, when combined or coupled with sufficient health capacity, such as COVID-19 tests and preferences to comply, ECQ becomes effective. And then adding COVID-19 PPE, ECQ is more effective in reducing daily incidence. In terms of lagged effects, which are actually included in our appendices, we find that the efficacy of ECQ in reducing COVID-19 cases persists over time, but in a reduced magnitude. And ECQ becomes effective when combined with health capacity and social-demographic characteristics, as consistent with the results of our real-time analysis. Next, we estimate model 4, wherein we actually incorporate the 5 different CQs and then the control variables using real-time analysis and lagged effects. And again, we use FEDID analysis. And basically, the hypothesis tests are again that individual CQs or quarantine are negative. That's the alternative hypothesis, negative. And basically, they reduce COVID-19 health incidence and mortality. We also hypothesize that the response of health outcomes to different types of lockdowns actually varies. So we assume that stricter or hypothesize that stricter lockdowns or CQs are actually more effective. And we also hypothesize based on the literature that poverty, urbanity, and population are positively associated with COVID-19 incidence and mortality. And finally, health capacity actually decreases COVID-19 incidence and mortality. Okay, we find that when we add social-demographic characteristics and health capacity, we find that our policy variables are effective, negative, and statistically significant when we expand our base model. In particular, in our MLR2 and MLR3 specifications, we find that MECQ tend to lower mortality rate by about 7% compared to those under GCQ. And this finding is robust across even if we extend analysis and use MLR3 or add health capacity variable. We also find that MECQ is effective in reducing cumulative deaths. We also find heterogeneity across the different types of CQs. In particular, the more strict CQ is, the more reduction in cumulative deaths. As you can see here, MECQ has a higher coefficient than MGCQ, which has a higher coefficient than CQ. However, we didn't find ECQ to be effective here in reducing cumulative deaths. And then in terms of reducing cumulative mortality rate, again, we find that MECQ is effective in reducing cumulative mortality rate compared to GCQ, whereas CQ is higher compared to GCQ, again suggesting heterogeneity across the different types of CQs. In terms of COVID-19 cases, so in the previous slide we analyzed COVID-19 deaths. Now we analyze COVID-19 cases, and we find that ECQ now here is effective in reducing COVID-19 cases consistently across the different specifications that we used and across the different um, health outcomes that we used: daily cases, male cases, and vulnerable cases. In addition, MECQ is also effective in reducing vulnerable cases and proportion of cumulative vulnerable cases. In terms of lagged effects, we find that the results are consistent with those in real-time analysis. Again, ECQ is ineffective without any control variables, but it becomes effective with health capacity and sociodemographic characteristics. We also find persistence in the efficacy of lockdown measures over time, and there is heterogeneity in the health outcomes across the different types of CQ, which persists a week or even 2 weeks later. Okay, just to summarize the results and to discuss the results. First, our real-time analysis suggests that ECQ is effective in reducing daily COVID-19 cases when coupled with health capacity and social-demographic characteristics. Second, ECQ is effective in curtailing COVID-19 cases, and this persists a week later but in a reduced magnitude. Third, we find that heterogeneity exists in the health outcomes across the different types of CQ, and that stricter CQs are more effective in reducing cases and deaths. And the results are robust across the different econometric specifications, and they persist over time. Among the control variables, which actually are found in the appendices and I didn't show for brevity, we find that urbanity matter more in reducing daily COVID-19 incidence in areas under ECQ, and this is robust across the time periods. A possible explanation would be that urbanity actually captures also income effect. And then population urbanity and other health workers, such as nurses, are more important in reducing all three COVID-19 death outcomes in MECQ areas than those in GCQ. And then healthcare workers, other than doctors, are also relevant in reducing COVID-19 cases in provinces, districts under MECQ than those in GCQ. In conclusion, so the Philippines is not inured to the devastating impact of COVID-19 on health and the economy. One of the government responses to mitigate the adverse effects of the virus and curtail its spread is an antiviral-based containment policy, cordon sanitaire or lockdown. The different CQs, delayed guidelines, and the insufficient information at times led to public confusion and frustration. For example, the omnibus guidelines on the implementation of CQs in the country were only approved by the IATF on May 15, about 2 months after the first CQ was imposed. The goals of this paper include the following. First, investigate whether the imposition of the different CQs was efficacious in reducing COVID-19 cases and deaths, which we measured in different ways. Second, test whether heterogeneity among different CQs exists in terms of their impact on the health outcomes. I also want to mention that different NPIs should be combined in order to have the desired effects on health outcomes, um, as attested to in the literature and by health experts or experts. And therefore, we also combined our policy variables with the use of PPE in the health sector. We also considered the health capacity of the country to cover for the two-pronged approach, which is flattening the curve through quarantine and raising health capacity in combating the outbreak or pandemic. The contributions of this paper includes constructing a novel panel data, and to the best of our knowledge, this is the first empirical study on the effectiveness of the different lockdown measures as a public health policy in addressing COVID-19 in the Philippines. And we also tried to integrate the role of health capacity and the innate characteristics of the provinces. The methodology that we used is a quasi-experimental analysis, DID, and then run fixed effects regressions to examine how health outcomes have evolved over time. We consider a generalized multi-group and multi-period DID approach and account for the unobserved heterogeneity across provinces. Inherent in the DID methodology is the consideration of the counterfactual question. Basically, what would have been the health outcomes of the provinces under a CQ had they not gone under treatment? And this is imputed from the observed outcomes for the untreated group. The results, first, CQ as a health policy is effective when combined with the health capacity and socio-demographic characteristics. And this is consistent with the following articles. Second, heterogeneity in the efficacy across the different CQs exists, where stricter CQs are more effective. And then the efficacy of the epidemiological interventions persists over time, a week or two, albeit in a reduced magnitude, as consistent with Bonaccini and others in 2021. Finally, other health staff, such as nurses and other health care workers, urbanity and population matter in reducing COVID-19 cases and deaths in areas that are under quarantine. I just want to say something about the worsening of COVID-19 health outcomes in the Philippines. And this can be attributed to the following, but not, of course, these are not just the only reasons. First, individuals at different degrees of quarantine measures have their own microeconomic incentives to comply to the guidelines and protocols instituted during a lockdown. There is also the inadequate health capacity and overwhelmed health system, and often confusing implementation of CQs. Some simple solutions, for example, in terms of social distancing, is using a proper informative naming convention like level 1 or level 2 that would be more helpful and could signal the intensity or strictness of the quarantine clearly. An aggressive and proper system for surveillance, monitoring, and isolating affected individuals. Full support from the government of healthcare workers, and a stricter implementation of wearing PPE in public spaces. So these are trying times, and although the findings of this paper show that some of the lockdown measures were effective, the next crucial steps include repairing the economy and strengthening the health capacity. Thank you, and this is the discussion paper that you can check out online. Thank you.
So thank you very much for that, Marge. So now the floor is open for any questions. So to start us off, I actually have a couple of questions from the YouTube channel. So again, I invite everyone to please type in your questions in the chat box, or you can do a raise hand so I can call upon you and you can ask your question personally. Okay, the first question is from Raymond Tan. This is from the YouTube. So thanks so much for presenting your interesting work, and I hope to be able to see the final journal version in the future. Do you plan to extend this model to account for the emergence of new COVID-19 variants?
Hello. Yeah, we haven't thought about it yet. So we will, I don't know, maybe we will consider it, but right now it's not in our radar. But that would be an interesting paper for sure. Yeah, so thank you for the question.
Okay, thank you for that. The next one is from Angeline Lau, also from the YouTube. Can you further elaborate on how robustness is determined in your models?
Okay, so basically when we say robustness, it's just basically or consistent results in terms of sign, in terms of statistical significance, and in terms of more or less magnitude. So yeah, that's how we consider robustness.
Okay, so are there any other questions from the audience? Sige, so I'll wait for the questions. Um, yeah, so maybe I just want. Okay, so Giselle has a question. Yes, Giselle, kindly address your question to Marge.
Morning, Marge and Kate. Marge, congratulations for your paper. I'd like to ask whether you considered the more proactive measure of contact tracing. I understand that in countries like Taiwan or South Korea, this accounted for a lot of the suppression of the transmission of infection. And I know uh, your data are macroeconomic, and I hope that the data obtained was accurate across the places where you conducted the study. But I'm also curious whether barangay officials and workers were considered. The LGU participation was considered because we know that it is not just the healthcare workers that contributed to the control of transmission, but also contact tracing by LGU workers. Thank you, Marge.
Yeah, thank you, Ma'am Gisela, for the questions. Okay, I think that the two main questions, yeah, so the have we considered contract tracing and whether we've considered barangay official workers in our paper. So the main limitation, ma'am, is because it's data limitation. So we don't have data, for example, on barangay officials or barangay healthcare workers, particularly in contact tracing. And then in contact tracing also, we sadly we couldn't find a variable for that also. Uh, yeah, so those are limitations of our paper.
Okay, thank you very much for that, Marge. Marge, yeah, I have a question. I saw because in one of your slides when you were comparing the results for all the different levels of community quarantine, you emphasized that there was a difference between the MECQ and the next level. But the previous one, like the GCQ, it wasn't so apparent. Would you Can you share with us your thoughts or insight on why this might be the case?
Why there is heterogeneity between the
And
two? Why are they
and
different?
and sometimes I think the results for the GCQ did not really show a similar trend with regards to reducing infection, or yeah, maybe that one.
Yeah, so I think the only explanation that I can um, think of right now is that, for example, MACQ, because it's a more strict lockdown and therefore it's more effective. And why GCQ is not consistent? Is that your question? Why the result is not consistent across different specifications? Uh, I'm not so sure, but so far we've seen that ECQ is the one that is really effective and consistent. Um, Maybe because in GCQ, the guidelines are not as clear, um, or the protocols are not that strict. So yeah, these are the only, unless my RA can think of an data set explanation. But yeah, right now.
Okay, thank you for that. So the next one comes from, oops, sorry. Okay, let me just, all right. So the next question comes from Rogelio Espirito. Is the 70% the safest herd immunity?
I don't know. This is beyond my expertise. I'm not an epidemiologist, but I don't think I can answer the question about the herd immunity.
Okay, thank you. The next one comes from Vic Ilag. So, what is the current protocol for a COVID-19 positive person in the community? And he has a follow up question. Is the lack of consistency due to the current strategy of not really controlling the multiplication of the virus in infected individuals?
Lack of consistency in results.
Maybe this was a follow up question to the to my question on the GCQ. Is that correct, Vic? Am I correct in my interpretation?
Yeah. Uh, hello.
Yes.
Hello, Vic.
Thank you.
Yeah. 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 Thank you.
Um, Probably, probably, but I don't know how to control for this in the paper. Um, yeah, are you talking about the reproductive rate?
No, actually, what I'm talking about was more if somebody's infected, what do they do? Do they keep the
Mm-hmm.
person isolated? Because I think if you're infected, you keep on multiplying the viruses in your body. So you might quarantine,
Oh, I see. I see.
but you're actually shedding lots of viruses. So you're not really solving the problem by quarantining per se. So you
Mhm.
have to stop the multiplication of the virus within the individual.
Yeah,
So example for
possibly,
like
possibly.
example for dengue, our approach because it's transmitted by mosquitoes, we spray, right? Or remove
Mhm.
standing water to stop the spread of the virus. Right now, I think simply isolating somebody is not sufficient. That's why I think it is still propagating. That's why we have these variants as well, which is a function of continuous multiplication of the virus.
Yeah, possibly, yeah.
Yeah.
Okay. Yeah, Marge, would you be aware on the current protocols of being implemented if you're a positive person, if you're positive with the COVID-19?
The only information I have is what's given by the government also regarding the protocol, which we all are all aware of, right? If it's not serious, then you can stay at home. If it's serious, then you get hospitalized. Um, yeah, but beyond that information given by the government, we can just rely on what's given to us.
Okay, thank you for that. So we have another question from Raymond from the YouTube. So he's going off tangent here, but as an economist, could you comment also on the possible delayed effects of the digital divide in education? It seems like this widens an already large socioeconomic gap.
Digital divide.
Mhm.
Uh, okay. Should I comment on this? Uh, I don't know. I don't think I can. I have an expertise to comment on this, so I'm sorry. Yeah,
Okay. I saw also in your model that you integrated demographics, right? Social demographics. Was it included in? You mentioned a while ago something about uh, those in poverty and how the results are affected when you integrate these aspects into the model. Can you
yeah.
elaborate more on that?
In social demographic variables,
Yeah.
we considered poverty, urbanity, and population.
Mm-hmm.
Um, so I'm thinking whether this question is somehow addressed by the socio-demographic variables. Uh, Education, I mean, indirectly could be captured in urbanity. Um, yeah, but yeah, aside from that, I don't think we've considered that.
Okay, thank you for that, Marge.
Ma'am Gisela.
Yeah, yes, Giselle.
Yes, I'd like to follow through the comments of the Ilag. And since Marge seems to be able to access some data from the government, I'm presuming that you've contacted some offices, unless your source is, public data. But the reason we're bringing this up is because uh, PASA actually has COVID bulletins, right? And we have one on the use of more medical preventive measures. Okay, and Vicky Lag is a co-author of that COVID bulletin. In particular, we're referring to the use of povidone iodine gargle, which is been shown to reduce viral load and therefore viral transmission, uh, especially during this time where the vaccine is not yet available to us. So we believe that these simple preventive measures would help in stemming the transmission of the virus. So I was just wondering, Marge, whether you would have a way to get this directed to some LGU officials or even regional national officials, just to show that there are alternatives. Okay, so you say that community quarantine works, but with other measures that would be taken. So, Vic and we have been trying to reach the DOH regarding this. So we have this Viber group, and it's nonstop. I mean, just Vic just keeps on sending messages to the group, but until now, we do not yet have any positive or proactive statements or declarations from sectors of government um, on this. It's a readily available, affordable uh, product in the market. I was just wondering whether, as an economist, and I recognize here the presence of others in the UP, Diliman School of Economics, like Manya Estera. I'm not sure if this is Michael Tan, our former chancellor, okay, who's also in the audience. Is there a way for us to at least try to get this promoted, perhaps on the LGU level? Maybe Quezon City, okay, with Mayor Joy Belmonte. Okay, so I think the economists, the epidemiologists, they actually have to work closely with other types of scientists, like the biomolecular scientists and immunologists, like Vicky Lag, and some of us in PAASE. And this is the way that we can make a difference as an organization or as an academic community. Thank you.
Thank you, ma'am.
Okay, thank you for that, Giselle. Okay, I have a few more questions in the chat. So one comes from Frelino Lansigan. So congratulations on your work. There were delays and or non-inclusion in the reporting of COVID-19 cases in some areas. How is this taken into account in the analysis? How is spatial difference of COVID cases within a province considered?
Okay, so first in the delay, so we've included that in the paper. I mean, we've mentioned that in the paper, but there is nothing we can do because we're just relying on the DOH report of the data, and they've said that it could have a delay of 14 days. or even more. In terms of spatial differences within a province, we only consider the aggregate data, which is provincial data. And so, because of data limitation also, as much as we want to consider uh, variations, for example, across barangays within a province, we are, like I said, restricted by the data. Um, and it would be a more daunting task to do it at the lower level. However, we've considered the four districts of Metro Manila, and so in which case we've considered at least the variation across districts in Metro Manila. So thank you for your question.
Okay, thank you. So there's a comment from Ms. Stella. So poverty relates to access to communication platforms. So this was mentioned in the study of the need for better communication from government to the public with regards to the nature of the CQs. Okay, would you like to add on to that, Marge?
Yeah, I think it makes sense. So she's basically saying, or in the response to the other question about digital divide, I think. But yeah, poverty could capture that aspect in the paper.
I
Thank you.
have I have one more question. Yeah, from me. So a lot of the analysis really comes from the data that you gathered. Can you tell us more about the source of this panel data and how it was generated, and like what are the main assumptions within that particular data set?
I think my RA can say more, but um, offhand, I know that we have combined 7 panel data sets, like I've mentioned, and that we constructed from 81 provinces and then using 4 districts of Metro Manila. But there's so many assumptions and so many things that we considered in constructing the data. One, like what was already mentioned, the delay,
Mm-hmm.
and then uh, another restriction would be some data sets were provided at a weekly level, so then we had to do a workaround. Some were just for one period, and then we have to interact that. So yeah, so there are many things, unless you have a specific question about the construction of the data set.
Oh, actually, my question maybe would be for other researchers who might be interested to work with the data that you have. Is the data available publicly, that maybe others can also look into it and do maybe a different kind of analysis with it?
Yeah, right now it's not public.
Okay.
It's not publicly available. We can share it if it's under review right now in the journal, so I'm sure they will
Mm-hmm.
require us to share it eventually. But I think we're also restricted by the guidelines in the journal. So, um, but we are willing to provide the data set as also required by the journal later. Yeah, so,
Okay. And Felino Lansigan says that I hope that you can send the results of your study to the technical working group of the IITF. Hold on, I lost it. So that they can also be guided. And
okay.
then we have a question. Okay, this will be our last question from JP Adriano. So thank you so much for sharing your study with the results showing that ECQ's effectivity coupled with health support and PPE, among other things, would it be economically viable forward to continue and recommend ECQ?
No, I also mentioned it. It's not sustainable. And like I said, moving forward, there are other things that we should focus on. Um, yeah, so like for example, improving our health capacity, and then the economic uh, recovery. Yeah, so I don't think ECQ or imposing a strict lockdown is viable at this point anymore. Yeah, but it was effective last year when when we were struggling with the pandemic.
Okay, sorry, I have a follow-up question. I
Mm-hmm.
know I said it's gonna be the last one. Okay, actually, yeah, for I'm going back to the data.
Mm-hmm.
Um, what kind of information were in the data sets, and were this generated by your group? Like, did you create your own survey, or was this something obtained from, from other sources?
Yeah, existing. So secondary
Okay.
data. So everything from DOH, either DOH, PSA, uh, or government pronouncements. So we sourced from different resolutions and EOs. Um, yeah, so it was a daunting task.
Okay, thank you for that. We have another comment from Stella. I like how the study underscored the interaction of COVID incidents, healthcare, and government intervention. The implication then is to consider an ecological approach to public health.
Yes.
Okay, and then I have some data and information mentioned by Vic, oh, like the one mentioned by Giselle a while ago with
Mhm.
regards to um, the initiatives of PAASE as well related to
Mhm.
COVID-19. So for those of you who are interested, you can download it from our chat box. Okay, so I think we have no more questions. But yeah, before we move on, Marge, do you have any final words for our audience?
Yeah, thank you for attending the presentation. The paper is a working paper, so it's still in progress. So there's still a lot of um, changes to be made. But the working paper you can download from the Global Labor Organization website. And I welcome all your comments. You can email me. I think Kay can share the email information later. And then if you have questions about the data sets, also you can ask me. Thank you.
Yeah, since you mentioned, so I can share. You already sent me a copy of the presentation. So is it okay for me to share it with our audience?
Yeah, sure.
Okay, thank you so much for that. I'll just send them a PDF copy. Okay, but before we end, I'll just like to announce our next. Okay, let me see. Okay, this is the one. All right. All right. So next week, okay. So next week we'll be having a group of speakers to discuss on their current work on how to allocate COVID-19 vaccines. So we'll do this on March 12th. That's again a Friday at 8 o'clock Philippine Standard Time. That's 7 p.m. March 11 for Eastern Time. So if you're interested, please register at bit.ly/allocation module. Right? And I will also send an invite. Okay, and then of course, as always, if you want to be updated, please don't forget to check our website, paase.org. And our webinars are recorded and posted in our YouTube channel, Paase Webinars. So thank you, everyone, and hope to see you again next week.
Thank you.
Thank you. Thank you. Thank you.
Bye.
Bye.
Thank you, guys.